Anyway, my brief tonight is to talk about how do we go about sexual rehabilitation as part of the overall physical rehabilitation of spinal cord injured patients that present to us in Ward 11. You will understand that a good 85% of spinal cord injured patients are males. There's a lot of theories around that, but the one that gets most common mention, of course, is the testosterone-driven, high risk-taking young male, and it would appear that is the case. And when you look at the injury profile, is the one that most ends up in this Ward 11, and roughly 85% of entries into Ward 11 is in the young male category. Because spinal cord injured individuals now live longer, of course, we have a greater age range of the spinal cord injured. And of course, the other few percent are delightfully female. Historically, sexual matters were not, at the beginning of the last century, that is in the early 1900s, sexuality was not considered as part of routine medical fare. That is, it was in the psychological realm, and of course Freud was the one who postulated that sexuality was all about the Oedipus and the id and the deep subconscious mind. It wasn't until the 50s that through Masters and Johnson's, who were medicos, a husband and wife team, and got involved in their physiology lab with sexual expression. That is, what were the physiological parameters that occurred when a person was undergoing sexual arousal, that it started to drift into mainstream, what was then mainstream medicine, but only marginally. Then came the great books by, and I've just forgotten the name, who wrote about the American male and then about the American female in their sexual expression. Well, the American society at that time was quite happy to accept the quirks and differences of the American male in its full expression of sexual norms. But when the book was written about American females, it wasn't ready because it had this idealized image of the American female, and she was the mother at home, and that was where the pedestal that I put her on. And she was supposed to be pure and virginal and wasn't allowed to have any sexual expression. So when it was written, the book was written, and I'm continuing to talk about this topic until the name pops up in my head of who wrote the book, but when it was written, in fact, it was ostracized in the mass media, and the person involved was in fact, their career ended almost immediately. What that illustrates is, of course, is that our sexuality is a very deep and abiding aspect of each of us, and we each have a nuanced and singular way of expressing our sexuality as part of our greater and bigger personality. So when a disabled person has an injury, and in that injury, part of their sexual expression or their functional sexuality is denied them, then part of them is lost, because it is part of their bigger, the way that you express yourself. And if you lose your erectile function, you can't express yourself as equally as well as, or males find it difficult to express themselves as equally as well. So part of them is lost. So there is something more than just losing the ability to move your lower limbs and to just actually get an erection. There's a deeper abiding and more meaningful context in which that's occurring. If you take, to carry on with the historical context, Masters and Johnson had given us in their physiological work the fact that there was, and when aided by Helen Kepler, worked out the fact that there was three aspects to it. That is your libido, that is the drive which made you seek and want and wish for sexual expression. Then the arousal, which in men was the erectile state, and Again, it's a vascular phenomena in men, and just like in women, it's a vascular phenomena, and arousal really indicates the same vascular phenomena in the vagina, but causing vaginal transudation. So erections in men, and of course in women, there's the female homologue of the male penis, that is the clitoris. So you get this double effect in women where there's clitoral erections parallel to the male erections, but there is also the vaginal engorgement with blood and transudation giving the lubrication that's necessary. But Masters and Johnson got onto the fact that there was orgasm, there was the excitement or the arousal phase, and then there was the sexual climax. And of course the sexual climax largely being recognized as being ejaculation in males. In females, there's two components to it, orgasm and ejaculation, and in females the orgasm tends to be the greater component, although there is the same equivalent in them to the ejaculatory response as there is in males, but largely it goes unrecognized. So having highlighted the fact that there were the three components, what happened when finally spinal cord injured people started living longer, so that they started to look at the quality of life, and sexual rehabilitation came part of that equation, then they wanted to look at those three aspects to it. And so as an easy way of structuring this talk, we can first discuss about about libido, then about erectile function or arousal states, and then finally the sexual climax, and how best that we may do something about it for the spinal cord injured. So if you take libido, libido is a central brain construct. It depends upon the sexually dimorphic nucleus, which sits right deep within the center of the brain in the hypothalamus, and that's sexually dimorphic. It's called dimorphic because it's subtly different in males to females, and there's a lot of discussion about that at the moment, how different it is and what does it lead to. But necessarily in that hypothalamic region, in the sexually dimorphic nucleus of the hypothalamic region, that's where your neurobiological substrate exists in order to give you a libido. So if you get a spinal cord injured, it does nothing to your libido. So you may lose your functional ability to get erections and even to have a climax, but it doesn't do anything to harm your libido. So you've got this drive to want to be sexually active, but you may not have the component parts to be sexually active. So it's one of those odd aspects to being a spinal cord injured individual. So if it's residing in the center brain region, two things basically will influence it. One is any brain damage, that is any change to the psychological and neurological substrate that gives it impetus. And secondly, the hormones which generate and make us into male and female, because male hormone in men, testosterone, has a dramatic impact upon the sexually dimorphic nucleus, constructing it into a male type sexual central brain nuclei. And as a consequence of that, and because spinal cord injured males are vulnerable to lower levels of testosterone, reasons for that are they undergo usually major trauma, and the inflammatory consequences of major trauma, that is the inflammatory cytokines, impact upon the hypothalamus and reduce testosterone through the hypothalamus affecting the pituitary and the pituitary gland affecting the testicles. You get a drop in testosterone levels. So major inflammatory cytokines released during mass injury and trauma to the body. That's one factor. Sitting for long times in wheelchairs, the lack of activity and the lack of exercise lowers testosterone levels. And if you, because of the lack of activity, become more and more obese, we know that obesity, particularly central obesity, releases again inflammatory cytokines which lower, through the hypothalamic pituitary gonadal axis, lower testosterone. And lastly, sitting in the wheelchair, it's believed that the longer term effect on raising the temperature of the testes, instead of them swinging free in the breezes of nature, they are at a slightly higher temperature for long periods of time, and that reduces their ability to remain healthy and well. And the last factor, I think, is often that there is a diminished neurogenic input. And so any tissue that lacks neuronal input and activity tends to atrophy over time. So spinal cord injured males are vulnerable for lower levels of testosterone. So even though they generally have no head injury, and therefore no problems with biological issues of neural pathways and that, there may be psychological factors and there may be hormonal factors. And so as a spinal cord injured male goes on in years, it is mandatory to start checking and monitoring their testosterone levels and to ask about their libido. Even though it can remain in them as a construct and it's not affected by the spinal cord injury directly, it's still vulnerable to the on-flowing and secondary effects of spinal cord injury. So that's one thing that we need to do in sexual rehabilitation, is to keep that in mind and to monitor for it, and particularly as spinal cord injured men get older and older. The second aspect was erectile dysfunction. Now, erectile dysfunction and ejaculation, of course, are different. Yes, they are primarily have their initiating neural input from the central brain area, but there are spinal nuclei. And for ejaculation, the spinal nuclei is around about T10 to L1 in neural of spinal cord level, and the erectile nuclei is down at S234. So they're in different aspects of the spinal cord. One's low thoracic, early lumbar, and the other is down in the sacral region. And depending upon the vertebral level, and noting, of course, that the spinal cord doesn't fill the spinal canal up in the cervical region, it starts out pretty well equal. But as you go down, the spinal cord doesn't grow as much as the vertebral column, and therefore the last aspect of the spinal cord, that is S234, is really about L1, L2. So if you have a lesion at around about L1, L2, you're likely to impact upon the erectile center, directly impact upon the erectile center. If you have a lesion that's higher up, you're likely to impact upon the ejaculatory center. If you have an direct impact upon the erectile center, that is the nuclei down in the lower sacral region, they can't operate on your behalf. And so you get no erections at all. So if you damage S234, spinal cord level, and the neural output from that center, that is the motor output going out to the penis, you will not, if you damage either of those, you will not be able to have erections. If you get up a bit higher than that, or lower than that, so preferably higher than that, then that center remains viable. So any thoracic or cervical lesions, the erectile nucleus stays patent, and what's more, it can feel any sensation. You may not, that is, you may have lost sensation from the belly button down, but the S234 nucleus, anything that touches you in the genitopelvic area, it will receive that signal. It will try and pass it up the spinal cord to let the central brain nuclei know that, hey, look, there's something going on here, we've got to get organized. But if it can't do that, it immediately sends the sensory signal across to the motor output side saying, let's get organized and give this guy an erection because there's something going on in the genitopelvic region. So you get what we call reflexogenic erections. Now, they're very, very suitable for allowing sexual intercourse to take place. And what we hope to do, but because they're a little bit more fleeting, what we hope to do is to accentuate that reflexogenic erection, make it more durable, make it much more reliable, so that during sexual intercourse it is robust enough and of good enough quality to allow enjoyable sexual activity to take place. So the whole aim in terms of erectile function is to work out, are reflexogenic erections still taking place? That is, if you're touched in the genitopelvic region, will you get a reflex erection? They can be a bit of a nuisance if you're just in the ward and you're having a shower or something and away this thing pops up, but at least it's a good parameter for us to know about so that we can use it as a basis for later sexual activity. Of course, that sexual activity in a spinal cord injured male will be different. Firstly, if you lack sensation below the belly button, if we give you good erections and you achieve vaginal penetration. You have no feeling. So what's it like to have no feeling but yet be penetrating a woman and attempting to enjoy a sexual encounter which doesn't have any feedback for you? Well, in that circumstance, and generally a lot of males that finally come to us have had prior sexual experience. So we say, look, what you've got to do is take your past memories of that and take that and work it into the current context, the current situation. Use your eyesight to appreciate the fact that you're with this beautiful woman and that you're involving yourself with her in sexual intimacy, and then marry it into previous experiences and make that, make it a more pleasurable and delightful experience. So it's a much more complex equation for a spinal cord injured male. Most spinal cord injured males will tend to have a reflexogenic erection, and so we can use either the oral PDE5s, that's Viagra, Cialis and Levitra, to try and augment a better quality erection, noting of course that these agents, the oral agents, have to get from the mouth down into the stomach, get absorbed, get into the bloodstream, travel down to the penis, where they actually work in the peripheral erectile tissue. And they accentuate the biochemical processes that allow a strong and robust erection to take place. So even though you're not getting a equally strong and robust neural input to direct the erectile tissue into producing best quality erections, so even though that's down and maybe only at 75% capacity, because the oral PDE5s are there geeing up the biochemical pathways, the combination of both often then produces a very robust and quality erection. If that's not possible, then we have the somewhat more difficult, but at least more reliable method of producing erections, and that is through intracavernosal injection, or what we call intracavernosal injections. And that's using substances like prostaglandin, which are vasoactive, and you can put in a tiny syringe and inject it directly into the cavernosal tissue, and once you get this vasoactive substance injected deep into the erectile tissue, it then provokes an erectile response without any neural input at all. And what's more, because there's little connections between either corpora cavernosa, that is the left side and the right side, talk to each other, then, although you're injecting in one side, the erectile process transfers across and you get a very good quality erection. Normally, if you get the dose right, the erection will last for an hour to 2 hours. Now, depending on how long you like to enjoy a sexual encounter, you may be left with a good hour or so in which you and your friend are sitting there wondering what you should do with each other. But nevertheless, it's reliable and good quality, and it allows for an enjoyable sexual encounter. If the oral PDE5s, that's Viagra, Cialis or Levitra, can't work or don't work effectively, if for some reason you become resistant to or the injections don't work, then of course down the track there is always the penile implant. We are less enamored by penile implants, one because we much prefer them in much older men, that is 50, 60 plus, because the lifespan of a penile implant is maybe 10, 15 years, and if you insert one surgically and you're a guy that's 25 or 30 years of age, then you're looking at another one at 45 and maybe another one at 55, and it becomes surgically almost impossible to put the second and third one in. And once you put a penile implant, you damage what is otherwise reasonably healthy erectile tissue. It's just the neural pathways aren't as good, or there are other factors playing a role in the demise of that erectile tissue. And it would be far better to try and reverse that than it would putting in a penile implant. There's a new technique that's just hot off the press called low-intensity shockwave therapy, which is akin to the lithotripsy, that is a high-intensity shockwave therapy that's used for crushing, crushing stones, kidney stones, dissipating them and allowing them to come out just as sort of bits of dust. But the low intensity actually induces vascular neogenesis, that is new blood vessels. And it's thought that it may be one way, that is if you give a standardized treatment regime once a year, you may keep the erectile tissue, particularly in the spinal cord, the spinal cord injured male who lacks neural innervation, you may keep it alive and healthy and very responsive. So that's a possible modality that may come into play fairly soon. So erectile function, we've got some cover on, or at least we can maneuver the erectile response to a position whereby it's probably as good as it would need to be, although not always perfect. With ejaculation, it's a different story. Ejaculation, the ejaculatory centre, at T10 to about L1, it doesn't have the reflexogenic pathway. So even if you did get involved in sexual intercourse and there was the usual penile sensory input, that is containment within the vagina, the sense of pressure, the sense of soft sensory feel, all that may be going into the spinal cord and even part of the way getting up the spinal cord, but because of the spinal cord block, it just doesn't get up to the central brain area. And it's the central brain area that really dominates the control of the ejaculatory process. But there is a little bit of sensory input that goes to the ejaculatory centre. And what we try and do after a spinal cord injury is try and rejig, and by a process of attempting to achieve ejaculation by vibrational intensity, see if we can't rejig the ejaculatory experience so that we make it much more a reflexogenic one rather than one that's central brain driven. Generally, spinal cord injured males, if they do get a reflex ejaculation, it tends to be a rapid ejaculatory experience, and so we try and slow that down, and there's some very good pharmacological agents that can do that. What they call the SSRIs, or antidepressants, if used in low dose and regular low dosing, they can increase the levels of serotonin in the synapse region and thus delay the ejaculatory process. So that's and tramadol, often used for pain, has a serotonin effect and again can delay ejaculation. So sometimes as a manipulator of pain, it can have a double-edged sword to it. So ejaculation can be assisted and helped in small ways, but nowhere near like erections can. And as a consequence of that, we aren't quite as good in dealing with ejaculatory problems in spinal cord injury as we are with erectile problems and with libido problems or libido issues. So overall, we have a fairly good take on, at least nowadays, of at least assisting the spinal cord injured male in regaining and becoming once again a sexually active individual and having that part of his life, and thus the flow and effects of forming relationships, having children, that is conceiving and having children, and so having a greater dimension to his life. We can now bring that into focus. And I must make mention that it was Tony Taylor, the urologist that used to work at here at Royal Perth Rehabilitation Hospital, was the first one to think about introducing sexual rehabilitation in the care and management of spinal cord injured men, and thus got me on board way back in 1992. It was his foresight that led to this revolution, and for a long, I'm still not even certain today whether other hospitals in the Australian domain, whether they have a sexual health physician, as does Royal Perth Rehabilitation Hospital. But for at least the first decade and a half, we were the only hospital, through Tony Lowe's activity, which allowed this to take place. Thank you for listening, and I hope it has been of some assistance to the web space as a means of allowing this message to get out and around. Thank you.
I often get asked about young males in chairs. Should they have sperm taken and frozen when they're first injured, in case there's reduced fertility when they're older?
It's a very good question. I didn't put a time dimension to that. The decay of the testicles usually takes at least, or to a degree that's noticeable, about 1 to 2 decades. Generally Ann Jack here would say, if they're not getting recurrent urinary tract infections, because usually if they're getting recurrent urinary tract infections, they're then getting associated with that a secondary chronic prostatitis, and from that backflow down the vas deferens into the testes, chronic orchitis. And in those men, she would recommend sooner rather than later that they did have sperm capture and freezing for future fertility questions. So one needs to be aware of what's happening to the young spinal cord injured male. If recurrent and frequent infections are there, then yes, I think sooner than later. But certainly as they're approaching the end of that first decade, it's a question that should be considered. And by that time, because they're usually somewhere in the age of 17 to 20 when they first hit the wards, they're much more likely to then be in that stage of their life where relationships, meaningful relationships, conception and issues of fertility are becoming a very dominant issue. So somewhere I would think around about 25 to 30 years of age, yes, it should be given a tick and looked at. Because it will be, it's best to, because they do, they just simply go down into the vas or the epididymis, flush in 20 mils of saline, and when you provoke the epididymis to a huge expansive volume, it immediately contracts back down and then flushes back out all that fluid along with all the sperm, the early, somewhat immature sperm that are there, and they're exquisite or very beautiful and good quality for conception. So the technique of capturing sperm is very easy and not really a problem. The only other issue is the cost of long-term freezing. And that's an issue that I think society should be looking at because there's nothing quite like maturing your life by having a child. You know, it's one of the big ticket items that which most of us really at some stage of our lives want to know that we've been able to achieve. So yeah, I think this is a very good question.
My injury was about 20 years ago, and about 10 years ago I suspect I actually had low testosterone levels, so I had my levels checked, and the range is between 4 and 10 or something like that. Mine was actually below the lower 3.4 or whatever it was. I assume it's gone down since then because my libido has gone down as well. Should I see a doctor about maybe getting testosterone supplements or whatever?
Yeah, look, I'm giving you a very simple answer to what probably is a somewhat of a complex question or clinical situation. But I do think you need to be retested. There can be reasons why the serum, the biochemical level that you're talking about, there can be reasons why it can be artificially low, both within the methodological assay and for other biological reasons. But if it's consistently down below the lower limit of the normal range, then something should be done about it. The consequences of having low levels of testosterone are what we call sarcopenia, that is muscle wasting, osteoporosis, that is bone wasting, because your testosterone levels encourage growth and maintain the male's physique, which is both muscle and bone. We have bigger, stronger bones and we have bigger, stronger muscles. As well as that, of course, it's extremely important in expression of your sexuality, both in libido and if you've got extremely low levels. It also has an influence on the erectile tissue, allowing correct levels of biochemical enzymes to be there in order to promote the erectile process. So there are important consequences that can occur of having low testosterone, and so yes, I do think it ought to be explored. You need to see your GP and express what you think is a real problem. In order to get hormone replacement therapy, you need 2 testosterones less than 8, so he'll have to do two assays.
That's easy.
Yeah.
Sorry, that's for sure I was going to say.
Yeah, and that'll be the case, but he'll probably then refer you to an endocrinologist so that you get a best value treatment and care and concern. All right.
For sure, thank you.
Another quick question I've been asked quite a few times from sporting perspective is spinal cord injured males is ejaculation and how to best ways to ejaculate as a spinal cord injured male.
Yep. The sensory input, which is most prolific at being able to cause an output, that is an ejaculation, is vibration sensation. To have an equally adept sexual partner, one of the thing that predicates all this, of course, is whether you've got any sensory awareness, sort of from the chest down. If you do, then the ability to ejaculate is far greater than if you don't. Because that sensory experience, even though it may not be getting up to the central brain area to provoke a sexual climax, is still getting, if your lesion's high enough, is still getting back to the ejaculatory center in the spinal cord and has the potential to provoke a reflex ejaculation. The only other way is by a vibration sensation applied to the prostate area, prostate and seminal vesicles. The prostate and seminal vesicles supply roughly 95% of your semen, and so if you can stimulate them massively, and of course the best way of doing that is through, again, vibrational stimulation or electro-vibrational stimulation through the rectal passage. Now, achieving that within the construct of a intimate and emotional sexual encounter is a much more difficult process, because your partner has to be willing to be open to these sort of suggestions. And that's where I found prostatic stimulation is a much more difficult venture within attempting to achieve in sort of the emotive aspects of sexual intercourse. Vibrational stimuli to the penile head can work, but it has to be a practiced and learned procedure, and often in order to get to that stage where you're inducing a reflexogenic ejaculation, you have to practice it long and hard, sort of as part of your homework at night, rather than only when you're in the classroom. And so it's a long and difficult road to hoe in order to get that, but one worthwhile doing. It's difficult to predict who will actually achieve it, but one, they've got to have an intact ejaculatory nuclei at T10 to L1, and secondly, best if they've got a lower body sensation intact, that is, they've got a partial spinal cord injury. Medications are usually that advance ejaculation are sympathomimetics, but to take them, for example, phenylephrine, adrenaline, well, you can't take adrenaline. They did in some stages slowly infuse it to see if it could induce it. Shoot ephedrine, but the side effects, the levels you've got to get to usually ensure that you're going to get side effects from the sympathetic effect. So oral medication in enhancing ejaculation is really nowhere near on a par as it is with the erectile pharmacology.
Ray, did you have a question?
Yeah, sure. Dr. Sherry Graham, I don't know whether it's fair or unfair, but maybe because I am a male, I heard your presentation from a male's perspective. It was presented as a male. If I was asking the contrary to Louise, from a female perspective, would I take all the three pieces of advice you gave in the three areas of arousal and sexual satisfaction to apply equally from a female's perspective?
It's a very good question. And the substrate to the answer is the fact that in utero, up until probably about 10 weeks, when we're about the size of our thumbnail, we are bipotent. That is, we can become either a fully fledged female or a fully fledged male. We can go down either pathway. Generally, the only thing that's making the difference that will determine whether someone becomes a male in utero or a female is the SRY gene on the Y chromosome. As long as that's there, then you're imprinted to become a male, because the SRY gene affects the primitive gonad, the undifferentiated gonad that can either become an ovary or a testis. It has the impact upon that to turn it either into a testis, and once you turn it into a testis, you flood the fetal body with testosterone, and that sets the process going of creating all the primordial genital tissue into a phallus rather than an introitus, because, sorry to be impersonal about it, but everything you've got and everything I've got can be transposed. The clitoris has the same corpora cavernosa and corpus spongiosum, but it just doesn't close around below and doesn't get as long as ours. The two labia majora are the parts of the scrotal sac, and the underlying extraurethral mucous membranes becomes the labia minora. And of course you then add in the vagina, and the remnant tissue that would have been the vagina in male is still as a nidus in the... I've got my remnant vagina, my remnant cords that would have gone out to the ovaries that have instead in me become testes. So the basic biological and the biochemical process in the clitoris is exactly the same in the penis. Women respond to Viagra and Cialis. So yes, there is that potential for all the advice I've given for the male to be equally applicable to the female. But the intriguing thing is, in the female, estrogen, God bless it, has a profound impact, changing the female's construct, the psychological construct of being a female, making it totally different to that, the testosterone influence on the male. And of course, there have been multiple books, and more recently, you know, men are from Mars and women from Venus. It is true, our brains are finally constructed differently. The way we think about things, the way we, I mean, it's clearly, if you do an MRI on a female talking, the whole brain lights up. You do an MRI, a functional MRI on a male, and you're likely to get 3 or 4 locations to light up. So our brains, and of course, the fact is that the brains are a high-level determinant of our sexual expression. So there are, and you find this in women, and we had a conversation about this to some degree, women adapt to their spinal cord injury far better than males. And they adapt to the changes in their sexual functionality. They can still have sexual intercourse without really needing Viagra, without really needing any other addition. The major impact in them is, and the major area that you really want to be more concerned about is when they conceive and are pregnant, because that's a different ball game altogether. But in terms of having sex, they can do so quite comfortably. It's just issues like how she perceives herself as a female. The body image question starts to raise its ugly head. Not saying it doesn't affect the male, it's also equally troublesome to be a male and in a wheelchair when you're sitting down low and you're trying to deal with other males that are standing up and taking the dominant alpha position. You know, it's a difficult paradigm for males as well. But females are far more adaptive. You look at, as another alternate expression of that, you look at relationships that were present before the spinal cord injury. If the spinal cord injury happens to the male, then it's much more likely the female will stay in that relationship. If the spinal cord injury happens to the female, it's much less likely that the male will stay in that relationship. So we are different. I know I haven't answered your question in specific detail, but I think there is a way, if women do have some problems in sexual expression and sexual enjoyment, then there are ways and means that that can be assisted. But it's not such, it doesn't appear to be such a great issue with them. Men can't, unless you have an erection, you can't really have vaginal intercourse. But if you don't have vaginal transudation, that is, you don't get the arousal phase, which is what the erection is in men. And even if you, and women for centuries have gone on without their clitoris having to be engorged and stimulated in order to have sex. I mean, they didn't know they were being deprived, but for centuries that was the case. So it's no different now. So in a sense, functionally, they can still have sexual intercourse without needing vaginal transudation, without needing clitoral engorgement. For the male, without an erection, it's a no-goer. So.
Thank you so much again, Dr. Cherry. I have to cut our discussion short
Yep.
now so we have time. And thanks again.